Good morning. This is lecture 13 in abnormal psychology, tape number 7 it's going to be. I've been talking about theories of depression and wanted to talk this morning about the learned helplessness theory of Martin Seligman. And to give you a little background on this, it really began as an animal model. Seligman was doing studies of avoidance learning with dogs, and if you'll remember that paradigm of a shuttle box and the light comes on with followed by a shock when the dog learns to escape or avoid. And he was doing studies at University of Pennsylvania, and the story goes he ran out of dogs. And another researcher in the department said, well, we've just finished some studies with these dogs, you're welcome to borrow them. And he started to run these dogs in the shuttle box, and they didn't learn to escape and avoid. Instead, they lay down on the shock grid and just whimpered and endured the shock. And another researcher might have said, that's a bad batch of dogs or whatever, let's get some new, fresh dogs in here. But he went and asked the other experimenters what they had been doing with these dogs, and they explained that they'd been doing classical conditioning studies using shock, so that the dogs had gotten shocked, but it was nothing that they could control. They couldn't escape or avoid. So he started experimenting, and indeed he found that if you give a pre-treatment where you have experience with uncontrollable shock, then you in his view learn to be helpless, and therefore when you're faced with a shock that you can't escape, you fail to learn that it is escapable. And he saw this as something of an analogy to depression, that when people are depressed, they feel helpless and don't feel they can do anything about the circumstances in their lives. And he did various studies with humans showing the same thing. If he gave you a problem, trying to think of the particular things. He had various unsolvable problems that he would give you. An unsolvable problem would be something where you had to keep something balanced, and he had it rigged so that the little ball would fall off whatever you did, so that you'd have this experience of uncontrollability. And then he'd test you on a separate test, and the typical separate test was anagrams. He'd have something like, anybody solve that anagram? What word can you make out of that? Starts with a P. Okay, it's patio. But the idea is he gave people over and over again 5-letter anagrams to solve, and in every case the letters were scrambled in the same way, so that if you started solving these after you solved them a few times, you'd discover that you could immediately solve them if you always took the third letter and made it the first and decoded it this way, you could solve all the anagrams. Well, what he found was if you just had an experience with an unsolvable problem, you took much longer to figure out the code in this. And again, he felt that if you again went into a task with a set that you were really not very good at solving problems, then you are less likely to catch on to the easy way to solve these problems. Just going to get rid of that. That was sort of the early version of the theory. He then went on to develop the theory in a more cognitive kind of model, and that's the one that I'm describing here. And in this model, he felt that there were some people who had a more helpless attributional style, that is, a more helpless way of thinking about things and the causes of things that happened to them. So that a person with a negative depressive attributional style would tend to essentially blame themselves when bad things happen and not take much credit when positive things happen. And I'll go into that a little bit more in a minute. But if you had that attributional style, that was a risk factor, a cognitive diathesis for depression. And if you had that diathesis and then a stressful life event occurred, so that you had this kind of diathesis stress model, then you would make attributions of helplessness. It's my fault, it's always going to be my fault, I can't do anything right, and that leads to, in the latest revision, to hopelessness, and hopelessness leads to depression. There's a research in social psychology on attributions and attributional style, and it suggests that there are actually eight typical attributions that we make when we think about something happening. When some event occurs, we tend to make judgments about the causes of those events. We all do this normally as part of our daily interaction and our daily understanding of what's going on with us and other people. And there are these four basic attributions. If you do well on a math test, you can make an internal attribution, either I'm good, have good math skills, or I studied hard, an effort attribution, and you're taking credit for it. It's because of me. Or you could say it was an easy test and I was just lucky, which would be the externalizing the cause. It wasn't me, it was the nature of the test, or it was the nature of just good luck. Now, when you're making a skill or a task difficulty attribution, you're making a stable attribution. That's going to be the case in the next exam as well. If you have good math skills, you'll still have good math skills. If the professor gives easy tests, he's probably going to give an easy test the next time. So skill or task difficulty is stable. Effort or luck are unstable. That's not you. If you studied hard this time, you might not study hard next time, and luck is luck. It's chance. So if you combined the internal part of the attribution, the stable and unstable, you get those four different attributions. Now you can also, for any of these, make an attribution that's global or specific. Specific would be, I have good algebra skills. Might not have good geometry skills, but I have good algebra skills. So it's relatively specific to the topic, and it doesn't necessarily generalize to other things. If you were very global, you might say, I'm smart. That would be a very global attribution, suggesting that you tend to do well on all kinds of tests. And again, you could go through each of these four, and they could be global or they could be specific. They could be, I studied hard this time for this test, but I may or may not study hard for the next one. Or more global would be, I'm really working hard in this particular course or this year in school or whatever it might be. In any case, the idea is that people may have a tendency to generalize and make one kind of attribution or another. And a negative depressive attributional style is one where when a negative event occurs, people make internal, stable, and global attributions. That's a depressive attributional style. Something bad happened, it was because of me, it's because of something about me that's always the case and will always be the case in the future, and it's something that's about me that carries over to everything I do. If a positive event occurs, the person is more likely to make an external, unstable, and specific attribution. It's wasn't me, it was just luck, it'll never happen again, and it happened in this situation, but it'll never happen in any other situation. So let's see what I've got here. The depressed person is the person who has this negative attributional style and is prone to depression because they tend to blame themselves for bad things and not take the credit for good things. The implications of this for treatment that Seligman has written about, he suggests that there are 4 general strategies. One is to sort of put the person in a more controllable environment, put the person in a situation where they'll have more of a sense of control and helplessness. And this could be possibly taking the person out of a dangerous environment, could be hospitalizing the person. Those all might be examples of putting the person in an enriched, a better controllable environment. Personal control training is essentially skill training. Teach the person, whether they be social skills or job skills or whatever, teach them the skills that they would need to feel more in control and more able to achieve their goals through skill training. Resignation training is the interesting idea of sort of helping people to give up unreasonable goals. One reason you might feel helpless is that your goals are unreasonable. You might feel helpless because you want to lose weight and you want to lose 80 pounds, when realistically maybe losing 30 pounds might be an obtainable goal, but not the huge weight loss. Attributional retraining is training in attributional style and trying to train people to take more credit for positive things that happen and not blame themselves so much for negative things. And that's actually the one that is most used. And Seligman has done some interesting studies in depression prevention, where he tries to teach people to have a more positive attributional style. He's also done things like have classes for salesmen to teach them a positive attributional style so they don't get depressed when they fail to make sales. So attribution retraining is also a part of some other treatments, including the treatment program that I do for depression, that I've developed for depression, that I'll talk about. Let me shift from talking, unless there are any questions about Seligman or learned helplessness. He's written some very popular books recently, sort of taking the other side of it and talking about learned optimism and the optimistic child and how to teach your child to be optimistic. The cognitive approach to depression is best exemplified by Aaron Beck and his cognitive model. He sees depression as essentially a cognitive bias, as a negative view of oneself, a negative view of the future, and a negative view of the world. If you're depressed, you tend to be down on yourself, to think of yourself as not worthy, as not able to do the things that you want to do, and the future seems bleak. This is the same idea of hopelessness about the future or helplessness about the future. And in general, the world around you looks fairly black. People, when they're depressed, tend to see the negative and the negative possibilities around them and tend not to see the more positive. Beck sees this indeed as due to a kind of cognitive distortion, and he talks about cognitive distortions at two levels. One is the level of automatic thoughts. And here the idea, and this is generally the cognitive approach, is that between the situation that you encounter and the emotion that you feel about that situation, there's some kind of interpretation. And often that interpretation in the cognitive sense is very automatic. That is, you're not aware that you're making that specific interpretation, but you are kind of automatically responding with a kind of thought that leads to the emotional reaction you have. If you go to work in the morning and you say good morning to a colleague who you're passing in the hall, and that person walks right past you looking at the floor, and you feel bad about it, it might be that your automatic thought was, what did I do to make him mad at me? And that would be a fairly depressive kind of thought. You feel bad, you feel sad because you've made the automatic assumption that that person must be mad at you somehow. Now you could also be curious, what happened to him this morning? Did he have an argument with his spouse or something like that? And have alternative kinds of automatic thoughts, and they would result in different feelings. The further concept is that what drives these automatic thoughts are underlying assumptions. People may have kind of depressive underlying assumptions. If somebody is unhappy in my environment, it's probably my fault. I'm always making people mad at me or something like that. Now, if you have that underlying assumption about your relationships with other people, then you're likely to have the automatic thought, what did I do to make him angry at me, and feel sad when you see the person in the hall. Further, Beck would argue that there are certain typical kinds of distortion that we make. Inexact labeling is when you respond to a situation by putting a possibly inaccurate term to it, and then you react to the term. You react to the label that you put on the situation. You have a feedback session with your boss, and he tells you about how pleased he is with certain things you're doing, but wishes you'd make some changes. And you come out of the session and say to yourself, "Boy, he really clobbered me with criticism." And then you react all day to, "I was clobbered with criticism," as the label that you've put it in. You don't go to what actually happened and examine that. You respond emotionally to the label that you've given to the situation. You're slightly embarrassed in a situation, and you say how humiliated I was in front of my colleagues, and you respond to the label that you've given rather than to the actual event. Emotional reasoning is the idea, I feel bad about it, therefore I must have done something wrong, rather than the reverse. What did I do, and was that something wrong? It's reasoning from the feeling. And if you tend to be depressed and feeling guilty in situations, then you'll even more so assume that things that happen are your fault. Magnification is simply the idea of sort of magnifying the negative, catastrophizing, that was the worst possible thing that could happen. And minimization is doing the opposite about something positive. It wasn't a big deal, it was just luck, etc. Kind of to use the Seligman attributional description. Selective attention is sort of seeing the negative but not the positive. Again, if the boss praised you for some things but then criticized you for something else, you remember the criticism and ignore the positive things. In any case, what this leads to then is cognitive therapy in Beck's developed by Beck. And cognitive therapy has a particular mode of operating with a patient. To begin with, Beck talks about collaborative empiricism. And what this means is that the therapist is to act as a collaborator with the patient, and the two of them are going to work on the problems that the person is having. And the empirical part is you're going to kind of develop little experiments to test out your attributions, your reasoning, the conclusions you draw about certain situations to see if they are accurate. And one of the things that's typical of cognitive therapy is identifying automatic thoughts. And Beck tends to use a little device of having the person keep with them a 3 or more column, depending on how complicated you want to do it, thing where you write down, if you feel bad in a situation, you write down the situation, the feeling you had, and then you try to identify the thought that led to that feeling. And then later, early on in therapy, you bring those in and discuss them to see whether that thought is really rational or not. And later on, you try to come up with a rational counter thought to the thought. An example that I once had with a patient, he had a discussion with a colleague over lunch about a movie, and he afterwards felt very down. And the question was what thought was making him feel down. And what had happened in the discussion was that he'd talked about how he viewed the movie and kind of what it meant, and the other guy had said that he had a different view of the movie and sort of told him what he thought it meant. And the automatic thought that he had was, he doesn't respect me. And when that was examined more closely, why doesn't he respect you? Well, he didn't think that my interpretation of the movie was right or the correct one. And if you went further and sort of examined this, the underlying assumption was, I have to be right and correct in everything I do, or people won't respect me, I'll lose people's respect. So both the automatic thought and the underlying assumption are the things that you want to help the person be aware of, and then to test out. Is it really the case that your friend lost respect for you in that conversation? What are some other possibilities? Maybe he thought your perspective was interesting and a different way of looking at things, and you gained respect in his eyes. How can you test that out? Maybe you should talk about the movie again and see what he thinks to test your assumption that you lost his respect. So part of therapy then is testing these hypotheses. Go out and test, was it really the case that you lost his respect? And that's part of the collaborative empiricism. It's largely done in terms of this kind of rational dispute, the questioning of the assumptions, and is that really the case? Might there be other ways of looking at it, other interpretations of the situation? Mex Cognitive Therapy these days is probably the most thoroughly evaluated treatment for depression. It's been the basis of many studies with many different depressed populations, and it holds up very well. It seems to do about as well as medications in trials that have used medications in contrast. And also there's fairly good evidence building that in comparison to medications for depression, the effects are maintained better. That is, that the relapse and recurrence rates are lowered with cognitive therapy, the assumption being that you learn some new ways of thinking to avoid depression in the future when you run into hard times somehow, and thus become more immune to developing depression. So it's a well-researched treatment, and these days what's going on is that they're adapting it to different kinds of problems. So there are now cognitive therapy for anxiety disorders of various sorts, and cognitive therapies that are being applied to substance abuse and to working with personality disorders and eating disorders, etc., etc. It's become a major modality. The basic assumptions about how you do the treatment tend to carry over from one problem to another. The types of cognitive distortions and typical underlying assumptions would vary from one disorder to another. Beck would say that in general for depression that underlying assumptions have to do with perceptions of loss, whereas for anxiety problems the underlying assumptions have perceptions of danger somehow. So that there's a basic theme that varies between the two of them. I want to talk a little bit about my own approach to depression, self-management or self-control model. And this is really based on some earlier research having to do with how people engage in behavior that we think of as self-control. How is it that people are successful in doing things like starting exercise programs or quitting smoking or going on a diet or whatever, things that we think of as positive self-control. And the model is one that was developed by Fred Canfer. Canfer said that if you view some aspect of your behavior as problematic and that you want to change it, suppose you're a smoker and you're kind of developed a cough and you don't like the fact that you burned a hole in another sweater or something like that, and you are ready to try to do something about quitting. Well, the first thing you're likely to do is self-monitor. You become more self-conscious about your behavior. You start to pay more attention to it. You might start counting the number of cigarettes, or at least at the end of the day, checking your pack to see how many cigarettes you smoked during the day, or getting very detailed about it and keeping a list of where you smoke each cigarette. But in one form or another, you self-monitor the behavior. At the second phase of this really kind of feedback loop is self-evaluation. You make some judgment about whether you're doing well or poorly. Gee, I smoked a pack and a half today, that's too much. I feel bad about that. Or I did fairly well today, I kept it to under a pack of cigarettes. You evaluate it against some kind of standard, and that could be a formal or an informal standard. You could be on some program where you're trying to cut down to a goal each week or something like that, or you could be just trying to stay under a pack or something like that. So you have some kind of self-evaluative standard against which you compare your behavior. Now, one modification we made to this was that to feel positive or negative about what you've done, you have to feel responsible for it. So there's an implied attributional process in there where you're making an internal attribution for the action. If you had a very, very stressful meeting at the office and your in-laws are coming to visit and whatever, and you smoked a few extra cigarettes, you kind of may say to yourself, well, that was because of all the stress of the day. It wasn't an ordinary day, and make an external attribution for the extra smoking. Or if you were in a meeting all day in a building where there was no smoking and you smoked fewer cigarettes, you might see it as, well, I was constrained by my environment today. To take credit for it, you have to feel that you had some responsibility for it. And the third part of Canfer's model is when you feel good or bad about it, you may influence your own behavior the way one person might influence another. That is with rewards and punishment, reinforcement. If you did well and cut down on your cigarettes, you may pat yourself on the back. You know, good for me, I'm succeeding, I'm going to be able to kick this habit. And that's rewarding and reinforcing and helps you to continue in your efforts to quit. On the other hand, if you did poorly and feel bad about it, you might, quote, kick yourself. You know, what's the matter with me? I'm never going to succeed in this. Maybe I should just give up. And that should function as a punishment, perhaps a helpful punishment to help you not have a bad day the next day. Well, this is a model that's been used elsewhere, and what we did was to apply it to depression. At the time that we started this, there were three theories around. There was Lewinson's behavioral theory that suggested it all had to do with external reinforcement and your response to that. Beck had just come out with his first book and said the depression was all cognitive and behavior was the consequence of all of the cognitive thinking. And Seligman actually came over and did a presentation about his animal model of helplessness. This is when I was at the University of Pittsburgh. So he had these three models, one very behavioral, one very cognitive, and then the animal model. And it seemed to us as if it was the proverbial blind men examining the elephant, that each one has is touching a different part of the elephant, and they describe the elephant in terms of the piece that they have approached. So we were trying to think about how could you integrate these, and ended up using the self-management model as an integrative model. And that led to saying that when people are depressed, or people who may be prone to depression, have problems in their self-management skills. And again, they may have these problems that make them at a risk for depression, but also they demonstrate these problems when they are depressed. The first is selective attention to negative events. And this is like Beck's idea of selective attention. People monitor the first two here are in the monitoring stage. They tend to monitor negative and not the positive things that happen to them. They focus on the negative, the bad things that happen, and tend to ignore the positive. They hear the criticism and ignore the praise. Second, people when they're depressed tend to selectively attend to the immediate consequences of their behavior as opposed to the long-term consequences. Self-management has to do with how you obtain long-term consequences in the face of immediate contrary consequences. If you are trying to quit smoking, you're trying to not smoke that cigarette even though smoking the cigarette would taste real good at the moment. Or if you are trying to lose weight, you pass up the rich dessert that would taste real good at the moment. If you're exercising to be healthier in the long run, the exercise may hurt in the short run. It may make you out of breath and uncomfortable in various ways, but you're doing those, you're accepting that sort of immediate punishment for the long-term goal. Well, when people are depressed, they tend to be less affected by the long-term and more by the immediate. Gee, I need to get that report written, but I just don't feel like it tonight. I think I'll, watch a movie on TV and have a beer or something like that. The immediate reinforcement is more important than the long-term. They have trouble working toward the long-term, more long-term goals. With regard to the self-evaluation phase, people who are depressed tend to have a negative attributional style. And the first version of this said that they tend to not take credit for positives and blame themselves for negatives. But then when Seligman developed his more full-blown model, we just kind of incorporated that into the model. So when you selectively attend to the negative and to short-term goals, you're likely to blame yourself for bad things and not take credit for the positive. People who are depressed also tend to be somewhat perfectionistic in their goal setting. Whatever I do is never quite good enough. Other people may do okay on things, but not me. And often it's kind of a moving goal. However I do, it falls short of what I should have been able to do. There's actually a study that had people perform a fairly complex task and evaluate how well they did, and then come back the next week and watch a videotape of somebody else performing the task. And the actual person in the videotape was exactly duplicating what the subject did. And depressed subjects tended to rate that person as having done better than they did. So if it's another person's performance, it's okay. If it's my performance, that's not up to par. There's a sort of a different set of standards for self versus others. The result of all of this, if you again only notice the negative things that happen, don't take credit for the positive, set high goals that you can't meet, you're likely to end up with excessive self-punishment and insufficient contingent self-reward. Self-punishment is, this largely sort of has to do with how people talk to themselves. People who are depressed tend to be self-punishing in their talk to themselves. What's the matter with me? I never should have done that. I'm going to look foolish in front of my friends. I might as well just give up, etc. And they're not very self-rewarding. I did well. I feel good about how I performed in that situation, how I accomplished that task. And the result, therefore, is difficulty towards moving toward long-term goals. And this model would say that the basis of depression is being kind of disconnected from longer-term goals. Our lives are organized by various kinds of goals. Goals you might have about school or career or health or interpersonal relationships all organize the things that you do during the day. You're doing things towards accomplishing different sets and hierarchies of goals. The depressed person tends to be hopeless and disconnected, hopeless and helpless and disconnected, therefore, from goals. I'm not going anywhere. I don't feel like I have any purpose. So the nature of the treatment program that follows from this, we do it as a group treatment. It's in a group format. It tends to be psychoeducational. That is, we teach people these different points that we just went over about the nature of depression. People who are depressed tend to selectively attend to negative events. And then when that is presented in the group and discussed, and usually there's some sort of exercise to do, then people are sent out with a homework assignment. And I'll go back and forth here, but this is the basic homework assignment. Keep track, since people who are depressed tend to pay attention to the negatives and not to the positives, keep track of the positive things that happen to you during the day. The positive activities list is what we refer to it as, so we want to emphasize that they're things that you do. The fact that it's a nice day out is positive, but we want what you should write down is sort of that you stopped to take a look at the trees and how nice the sky looked this morning or something like that as the positive activity. And you can also list on the log positive thoughts that you had about yourself or things that you did or accomplished. You feel good about the nice conversation you had with a friend this morning, something like that. Then there's as we present other ideas about immediate versus delayed effects, anything that you do may have an immediate or a delayed negative or positive effect. And you can make a little 2x2 table for this particular action. What's the immediate positive, immediate negative, long-term positive, long-term negative, and try to encourage people to do things that add things to their self-monitoring log in the next week or two that represent long-term positive outcomes. Write a letter to your friend, not because it's so much fun to do right at the moment, but because it'll enhance your relationship and you'll get a letter back and that sort of thing. Get the job done early so that you have the weekend off or something like that. And write down those things that you're doing because they have a positive long-term effect. We do attributional style retraining, a couple of sessions on responses to positive events. Do you tend not to take credit for positive events? A couple of sessions on negative events. Do you tend to overly blame yourself for negative events? We ran a study over at the VA hospital a couple of years ago, and I remember one long discussion about somebody who had a flat tire, and they were blaming themselves for having the flat tire. And the question was, how much responsibility do you have for the flat tire versus the nail on the road, or whatever it was, and how much should you blame yourself? Well, I didn't check the tires, and et cetera, et cetera. He wanted to blame himself for the flat tire. We do a session on goal setting to go back to that, to teach people how to set more realistic goals, and we have them pick some goal that they'd like to work on, some relatively short-term goal. Gee, I want to get that garage painted, or I want to start an exercise program, or start looking for a new job or something like that. What goal, set your goal in a positive way, something that you want to increase, not something that you want to stop doing. You want to eat more healthy foods more rather than stop eating unhealthy foods or something like that. And then break it down into sub-goals. What are specific things that you can do to work on your long-term goal? And they can either be steps along the way in a sequence, or they might be just different things that you could do to work towards your goal. I remember a woman in one group that we ran years ago who's decided that she'd always really liked cats, so her goal was to do more cat-related activities. And okay, but she made up this nice list of, I'm going to look in the phone book to see if there are any cat organizations around, and I'm going to go to the library and get some books on cats, and I'm going to, she had like 5 or 6 things that she could do that had to do with cats, and that was great. Then the final sections really have to do with talking to yourself in a more rewarding or positive way. And we have people write down, do things like, there's a couple of exercises here. One is, if you were pleased with somebody else's performance, what's your typical phrasing? What would you say to somebody else? Gee, that was great. I like the way you did that. Now turn it around as a phrase that you might say to yourself. I liked the way I did that. I thought that was great. And practice saying that to yourself when you accomplish something during the day. Notice your accomplishments and write down in your self-monitoring log the positive self-statement. Now, we've had people say, aha, you're teaching me to be the sin of pride, to be bragging about myself. This is bragging. And we say, no, bragging is when you try to coerce somebody else into agreeing with you. If you're just saying it to yourself, it's positive self-esteem. It's recognizing that you are able to accomplish things and to get tasks done, etc. And we end up with another, we don't actually focus on self-punishment because, again, we feel people are probably doing that themselves, and we're trying to substitute more self-reward. The final thing that we do is have people come up with an assets list. Write down the 5 best things about yourself. You've been noticing that you do succeed and do accomplish certain things. What are the 5 best characteristics about yourself? It doesn't seem to be like a terrible task, but if you've got a group of 8 depressed people sitting around in a circle, that's likely to fill up most of the session. One of the ones that I remember was a woman who said she just couldn't think of anything positive to say about herself, and one of the other women in the group said, gee, you've been telling me about the needlework that you do. Why don't you put down something about your needlework skills? She thought about it and said, well, I guess, yeah. So she wrote down, I'm sometimes okay at certain kinds of needlework. It was like, 4 qualifiers in the sentence, and people said, now come on, can't you just say I'm good at needlework, something like that? And she finally, all right, I guess I can say that about myself. We are all kind of socialized that you shouldn't say positive things about yourself, and it's sometimes difficult to sort of accept that it's okay to have the thought that you're good at certain things. Well, we've done a number of studies with this program in the group format. It's sort of common wisdom that you shouldn't see groups where everybody in the group is depressed. The assumption is that they'll all kind of reinforce each other's depression. Gee, it's a crummy world out there. Yes, it is. Yes, it is. Yes, it is. Yes, it is. But we find it actually very useful. People feel like they're not the only one who has certain kinds of problems or feels the way they do, and they tend to be very supportive of one another, and good group cohesion often develops. They're helpful to one another and point out each other's successes, and we like the group format. We've done studies comparing it to kind of contrast forms of therapy and to alternative therapies, and in recent years we've been doing the program with different groups. We most recently did it with a VA study where we've done it with battered women, with women with people on dialysis. We did it actually with one group of adolescents with a slightly different modified version of it, and seeing how it works, and it does seem to work fairly well with a variety of populations. Any questions or comments on that or on depression in general? Yes?
Have you ever heard of people recently that they just wrote The Secret, which is the positive thinking attitude? It's a controversy.
The positive psychology? That's actually Seligman is kind of behind that. When he was recently president of the American Psychological Association, his major address and thrust was to say that psychology for too long has focused on the negative aspects of life, on psychopathology, and that we haven't studied enough what makes people happy and what leads to feeling positive about yourself, etc. So it's kind of started a trend around the country. People are teaching courses at various universities on positive psychology, and books are coming out on how to be happy and how to feel better. In some ways, my program, I've always thought of it as you can actually see it in three ways. One is that it's breaking down depression into little pieces, and we're helping people try to deal with each piece. The second is we're teaching them self-management or self-control skills in the context of depression. If you want to make changes, you need to self-monitor what you want to change. You develop a evaluation against goals, and reward yourself for doing it. And the third way of thinking about it is sort of the positive psychology way. What we're teaching people is to go from depressive, negative ways of doing things to doing things that are the behaviors of positive self-esteem. What do people who have positive self-esteem do? They can recognize that there are good things that happen to them as well as bad. They can take some credit for the positive things that happen. They can pat themselves on the back for those things. They can set realistic goals and pursue them successfully. Those are all, that's positive psychology in many ways. And if you look at the curriculum of some of the positive psychology programs, those are exactly the things that they're doing. But that's it's a fairly new trend that's getting very popular, is to do the positive psychology side of things. Any other questions or comments? All right, let's go from positive to negative, and we want to talk a little bit about suicide as a problem that is related to depression, but not entirely related to depression. But it's an important topic in and of itself. Suicide has been part of human history going back to fairly ancient times. We had the example of Socrates, who drank hemlock as an honorable exit, as an alternative to being executed. Escape of military defeat by suicide has been recorded in the Bible. There's the mass suicide of Masada, where the people of the village jumped off the cliff rather than surrender. There's actually, in a very different society, a similar example in Hawaii when King Kamehameha united all of the islands. He attacked Oahu, and the Oahu defenders were told not to come back if they didn't win, and as they were forced to retreat up the canyon to the Pali, the cliff on the volcanic mountains, rather than surrender, they jumped off the cliff to their death. And into the 1920s, I read a book about somebody who lived in Hawaii in the 20s, and you could find bones of the soldiers still on the cliffside. I spent a summer in teaching at the University of Hawaii, and I commuted over the Pali where the mass suicides had taken place. Suicide as a sin or a crime is a later development. Around the 6th century, the idea of, in the Western world, of sinfulness of suicide came into the writings and descriptions. Suicide, the idea of suicide as a crime, peaked in the United States in the 19th century. There are actually examples where people who committed suicide, that their corpses were hanged publicly as their punishment for having committed the crime of suicide, and the idea was to warn other people about how terrible this was, but although I'm not sure how effective it would be as a suicide prevention, but that was the idea, was to warn people of what punishment you'd get. Modern suicidology is not only concerned with people who commit or attempt suicide, but also with people who are at risk, with families, survivors, caregivers, so that's a much broader kind of perspective. In the United States, in the most recent statistics, it's the 12th leading cause of death. Actually, my notes from a few years ago said the 9th leading, but I checked it against the Center for Disease Control statistics this week, and it's now 12th. 8th for males, 17th for females. It's the 4th leading cause for people 15 to 34. The leading cause in that group is accidents, then actually I believe it's homicide and cancer, and then suicide. It's also somewhat higher in the elderly, particularly elderly males. It's high in people who are in their 60s to 80s. There were increases in suicides for younger children in the 90s. The rates for adolescents have been interesting. They went up during the 80s, then they plateaued, or if anything, went down during the 90s, and now there seems to be a slight trend back up. And there's a lot of debate about why that might be. It's going on. There was a debate on an internet listserv that I'm on where somebody had written that they thought that it was associated with the fact that in the last 10 years, the use of antidepressant medications with depressed adolescents has increased, adolescents and children. That's become controversial. There's a continuing controversy as to whether or not antidepressants may be related to suicide. And I've read reviews both directions that suggest that there's some evidence that taking Prozac or one of the other newer antidepressants that may increase the rates of suicide. It's questionable, and somebody else sort of argued the opposite and also pointed out that suicide rates in other countries have gone different directions, even though they had the same kind of increase in use of antidepressant medications with adolescents. It's higher in some other countries, in some of the Scandinavian countries. Japan, Austria, and Hungary tend to have higher rates than the U.S. The U.S., there are variations in location. San Francisco tends to have a high rate, and some people blame that on the Golden Gate Bridge as an attractive place to commit suicide, and in fact there are quite a few suicides annually off the Golden Gate Bridge. It's been a big argument as to whether or not to build, and I've heard that this argument was renewed again recently. Should you build a long fence along the Golden Gate Bridge? It'd be very expensive, and would people just go to another bridge? The suicidologists think no, it's become such a famous place to commit suicide that if you put up a barrier or a wall, you probably decrease the number of suicides. Gender and ethnicity. Men commit more suicides than women, although women may make more attempts. Statistics on attempts are very difficult. Someone's estimate is 4 to 1 women to men, but what an attempt is and whether it gets somehow officially identified is very difficult. Probably other estimates suggest that there are 8 to 25 attempts by men or women to any actual completion. 73% of suicides in the United States are by white males. White males have twice the rate of suicide of African American males in the United States, and males in general are higher than females. Other demographic factors that are related, unemployment, suicide rates are higher in urban areas than in rural. Marital discord is often associated with suicide, and sexual orientation. Gay and lesbian populations tend to have higher rates of suicide in the U.S. One of the differences between suicides by men and women is that men are more likely to use more lethal methods. Men tend to use firearms. 80% of suicides by men are with guns, followed by hanging and jumping. Women are more likely to take overdoses and use cutting, which they're more likely to survive. Prediction and prevention of suicide is very difficult, and these are 4 reasons why it's difficult to predict and prevent suicides. One is the statistical infrequency. It's relatively rare, and the practical question often is how many people should you hospitalize to prevent one suicide? If you hospitalized everybody who has suicidal thoughts, the hospitals would be full of people who probably didn't really need to be there. But it may be worth hospitalizing some people unnecessarily to get the 1 or 2 who actually would benefit from it. So just statistical infrequency makes it difficult. The second is that it's often suicides are committed during a particular emotional state. A high proportion of suicides, 15 to 20%, are associated with alcohol or other drug consumption. So it's when a person may often be in an altered emotional state chemically. Also, simply when people are very upset, they may impulsively commit suicide. Situational factors. remember whether I mentioned it here in another context, but I knew of a guy in San Francisco who was going to go jump off the Golden Gate Bridge and drove his car towards the bridge and got into a traffic jam and sort of decided to heck with it. I'm not going to sit in this traffic jam, and turned around, went home and had dinner. Sometimes it is the availability of the situation that determines whether or not the person commits suicide. Having a firearm in the home is a risk factor in that if the person has the availability of the means, the probability of a particular emotional state leading to suicide is enhanced by that situational factor. The final reason is that some suicides are very intentional and determined, and if somebody is really determined to commit suicide, it's very difficult to prevent them from doing so. While I was at UCLA years ago, there were a couple of suicides. It was very unusual for the suicides. There was first suicide that I've ever actually had in an inpatient setting, and this was a patient who was under 24-hour watch for their suicidality, but during the couple of minutes between checks of them during the night, the person strangled himself to death with a coat hanger, wound it around his throat, and they got rid of wire coat hangers after that in the hospital. Another young man who had tried to commit suicide by jumping off a bridge onto a freeway in Los Angeles and had managed only to break his arm doing that was in the, again, in a locked ward with round-the-clock observation, which meant there was somebody assigned to him alone all day long who was sitting with him in the day room. When somebody unlocked the door, opened up the door onto the ward, and paused for a minute to finish a conversation with somebody in the hall, and the patient bolted from the day room, pushed this person out of the way, ran out the door, ran down the hall, used his cast to break a big plate glass window on the 6th floor and jumped out before anyone could get to him. He survived that. He landed on kind of the canopy above the entrance, had many broken bones, and was in very bad shape, but was right there in the middle of the hospital complex. And about 6 weeks later, when he was released from the hospital, he came back to the ward to thank everybody for how kind they'd been to him. His depression was gone. His suicidal thoughts were gone. I thought it was kind of do-it-yourself shock therapy, that it may be that, as with electric shock, the physical shock of all of that and the physical recuperation may have helped him sort of regain his desire to be well and whole again. And just one more anecdote along this line. There was another woman who left the hospital against medical advice. The psychiatrist treating her thought that she was suicidal, but she would not admit to it, and there was really no way to involuntarily hospitalize her, so she left the hospital. And reconstructing over the next couple of days, she made phone calls to kind of all of the relatives with whom she'd had arguments, and she kind of settled things with them. She made all sorts of other arrangements. She got the insurance policies out and had them all sitting on her desk, and made other kinds of arrangements. And then she drove out to hillside overlooking the ocean with a pistol, and put the pistol in her mouth and killed herself. And she, in terms of making arrangements, she had brought a sheet along so that when she was found by the police, they'd have a sheet readily available to put over her. If you're that determined and planful in a suicide attempt, it's very difficult for somebody to detect and stop you from doing it. So, suicide prevention is a big problem. How do we prevent suicide? Talk about some of the other risk factors. Psychiatric diagnosis is a risk. This is, in many cases, an issue that is relevant to psychopathology. And the idea of suicide as a mental health, I've talked about the history before. The idea of suicide as a mental health issue is really a pretty much a 20th, 21st century development. Depression has an increased risk for suicide. Bipolar disorder has a high risk. Around 20% of people with bipolar disorder commit suicide. Alcohol and substance abuse, schizophrenia, personality disorders, and even panic disorder has a slight increased risk for suicide. Other kinds of risk factors, besides a mental health diagnosis, a prior attempt. Once a person makes one attempt, the probability of a second attempt is increased. Does the person have models? Do they know somebody else who committed suicide? This is a big issue in schools. If one student in a high school commits suicide, what's the appropriate response? Should you get everybody together and talk about it, or should you not talk about it? The question is, there's some evidence of contagion suicides. One person commits suicide and then somebody else follows up by sort of following the model and committing suicide also. Does the person have models in their history? Do you have a family member who committed suicide at some point? Does the person, that's something of a risk factor. Availability of firearms, having a gun in the home that's available. People have different reasons for considering suicide. Hopelessness about the future and escape from pain, escape from a painful, either psychologically or physically painful life are risk factors. And talking about it. Sometimes there's something of a myth that says if you talk about suicide, you won't actually do it. That's not true. Lack of social resources, if the person is sort of isolated and doesn't have a network of some sort. Being in some kind of emotional crisis. Family history of violence. Making arrangements is a sign that somebody may be contemplating suicide. Giving away prized possessions is sometimes part of that. Give things away to people who you want to have them after you're deceased. What do you do if you encounter a family member or a friend who you think may be suicidal? First thing to do is to ask, to talk about it. Don't feel that you can't bring the subject up. You need to say, gee, I'm worried about you, worried about the way you've been talking. I wonder from what you have said whether you're thinking about harming yourself or suicide. You sound so pessimistic talking about death and suicide. Listen to the person. Try to understand what's going on with them and what's bothering them. Don't challenge them. That's a big problem. You don't want to say, oh, things aren't really that bad. You don't really want to commit suicide. You're just putting a wall between you and that person if you do that. Be supportive. Take charge if necessary. You may have to say, look, I'm telling your parents, or I'm taking you to the hospital, or I'm going to do something to intervene here. Make the environment safe. Sometimes for people, just doing things like finding them a place to stay with a friend or something like that while they're in a crisis can be helpful. And finally, I heard a talk a number of years ago by somebody who worked with suicide. So this is really for mental health professionals. And he argued that you have to believe to work successfully that suicides can't be prevented, again, that you're not going to put yourself in opposition to the person, I'm going to keep you from committing suicide. That suicides may be reasonable, although you don't want to say, no, suicide's never acceptable, and the person says, oh yeah, you don't know what's going on in my life. If you communicate those first two, then you can get the person to consider alternatives, and that's the goal, is to get the person, when people are depressed in particular, they often have kind of tunnel vision and don't see any way out for themselves in certain situations. And what you want to do is to say, wait, suicide is forever, stop for a while, and let's see if we can't come up with some other alternatives. There are some good assessment tools. There's a hopelessness scale that's useful, and a scale that I like that's called the Reasons for Living scale that helps people assess reasons for not committing suicide. We're about out of time, so we'll take a break and come back with the next topic.